So I just wanted to talk about where we are now and a little update on variants and to talk about the vaccines and all the talk about boosters and so forth. So as far as New York City, this is last week's information from the Department of Health. You can see this goes back to the beginning of the pandemic here when we were having several thousand cases a day. We had the lull and then the winter upswing, which actually exceeded in terms of numbers of cases what we saw in the beginning of the pandemic, and then another lull in the summer. And then for New York City, this is what we're seeing with the Delta variant, and you can see it's already starting to curl down, which is encouraging. It's early yet. It's peaked at a much lower rate, despite the fact that Delta is much more transmissible. And that's probably due to vaccinations and previous immunity. In terms of hospitalizations, you remember that the peak of cases in the winter was actually higher than the peak of cases in the beginning of the pandemic, and now we're going down. In terms of hospitalizations, the beginning of March, April of 2020 was by far the worst. No one had any natural immunity. We had limited testing, limited treatment. And even with still having limited treatment here in the wintertime and really pre-vaccine, we still had a much lower peak of hospitalizations, probably due to immunity in the population from previous infection. So even though we had cases, and some of those cases may have been people who previously had the virus, they were not getting as sick, and we had many fewer hospitalizations during that period. Although cumulatively we had a lot of hospitalizations, it didn't spike as badly. And here you can see that we're having many fewer hospitalizations in this latest wave. In terms of deaths, you see the same thing. The death rate is way down, which is a wonderful thing. Now, even though we did see a bump up last winter, it was nowhere near as much as the beginning. And we're at a very low rate now. They published some data in terms of COVID-19 cases and hospitalizations in adults in New York State by vaccine status. And this was in the MMWR, which is a big CDC publication, just a week or so ago. And it covers the period from May, July. And remember, vaccines for healthcare workers and people kind of early started really in January, but most folks started having availability in sort of March, April, May. So this covers that period from May to July. You look here, I just put boxes around some of the important information. And starting in May 3rd, we had about 6 million people fully vaccinated. By July 19th, that's over 10 million. And for percentage-wise, in terms of population, it's about 40% in May and up to 65.5% now. And then this is new cases here in the middle, and you can see although the cases are going up, May we were down to about 700 during the summer. We got down to the 300s per 100,000, and now we're well up in both the vaccinated and the unvaccinated population. But the thing to look at is the rate of infection in the vaccinated population, and that's 3.9 versus 21 per 100,000 in the unvaccinated. So a huge difference in terms of who's getting new infections. And it's important to emphasize that most vaccines, including COVID-19, are not really designed to prevent infection 100% of the time. So infections can happen, but what really vaccines are designed to do particularly is to prevent illness from an infection, and certainly serious illness and hospitalizations. And you can see that same thing. The overall estimated effectiveness of the vaccine versus infection alone is about 80% during this time period. But if you look at for hospitalizations, there's only 0.19 per 100,000 in the vaccinated group versus almost 2 per 100,000 in the unvaccinated. And the vaccine effectiveness rate for preventing hospitalization is all the way at 95%. So again, not a perfect vaccine, but these numbers here in New York are pretty dramatic in terms of really demonstrating now in the world of vaccines that not only are you less likely to get an infection, but if you do, you're much less likely to be sick enough to be in the hospital. So this is sort of just a graphic way to show it. It's in all adults over 18 years. Here's cases per 100,000, and this is the estimated vaccine coverage and effectiveness. And just to look at two of these lines, these are the cases per 100,000 during that time period in the fully vaccinated, and then this is the cases per 100,000, that red arrow in the unvaccinated. So really dramatic difference, both in terms of vaccine effectiveness, the number of cases. And the same thing you can see with hospitalizations, where this is almost a flat line down here in the vaccinated group, but here you can see it ticking up in the unvaccinated group. Summing it up, if you look at the whole year between January 17th and August 17th, January being when vaccines first started rolling out, the unvaccinated accounted for over 96% of all cases of COVID-19, almost 97% of all COVID-19 hospitalizations, and over 97% of COVID-19 deaths. So very, very dramatic differences in terms of both infections and illness group that's vaccinated. And they go on to note that as cases have increased recently, particularly from the Delta variant, the rate of infections in vaccinated people, which is called a breakthrough infection, has also increased. But the most recent data show the crude case rate for unvaccinated people still is over 3 times higher than it is for the fully vaccinated. And remember, it's kind of a mathematical thing, but we see the absolute number of cases in the vaccinated population is going to grow as the vaccinated population grows. In theory, if we had a 100% vaccination rate, then people would say, oh, look at all these cases in the vaccinated, but we still know that there's infection in the vaccinated. But as we have more and more people vaccinated, those numbers grow, but again, it protects from serious illness. Boosters versus a third shot, and the terminology isn't that important, but some vaccines do require 3 shots, a 3-shot series to give protection. For instance, the most commonly used vaccine for hepatitis B for many years was the 3-shot series. You got one day 1, and then in a month, and then in 6 months. For human papillomavirus, kids get day 0, 1 to 2 months, and then 6 months. So many shots were designed out of the gate to require 3 shots to get adequate and long-lasting immunity. And we don't really call those booster shots, we just call them a 3-shot series. A booster shot is really something more, for instance, like the tetanus, diphtheria, pertussis vaccine that we know over a period of 10 years, a lot of people that immunity can drift down. And so we give people every 10 years a tetanus, whooping cough booster shot to kind of boost their immunity back up. Not that important to really make that distinction, but in the very severely immunocompromised, there's been a fair amount of study looking at COVID-19, mostly in a transplant population, so people with liver transplants, kidney transplants, lung transplants, and so forth, where they're really being maintained on immunosuppressive medications so that they don't reject the transplant. And in that group of people, in a fair number, up to half in a lot of studies, after just the regular 2 shots of a Pfizer or Moderna, which is mostly what's been studied, it didn't look like they mounted enough immunity. And so in that group, we're really moving to the thought that, again, out of the gate, folks that are on immunosuppressive medications really need a 3-shot series. Now, the timing of it is a little up in the air, and really, honestly, the timing of all the vaccines was educated guesswork. It might actually turn out that both for the existing vaccines, that giving the first shot today and waiting 2 months is better in terms of providing immunity. We don't really know that, although again, in England, for instance, when they were low on vaccine in the beginning of the pandemic, they were spacing out the vaccines just to preserve the vaccine and provide at least 1 shot to more people. And so we'll probably learn more about that. There's been a lot of talk about whether or not the general population, but that's ongoing. The FDA and the CDC are going to meet middle of September on the 17th and go over data. It may be data that's predominantly Pfizer. Hopefully the general principles will hold and we'll get some clarity on whether and when they're going to be recommending booster shots to the general population who is fully vaccinated. Different intervals of the existing shots might end up ultimately being a better way to do it. One of the things that that's most important and a moral ethical question for places like the United States that have a lot of vaccine. Should we be doing booster shots before the rest of the world has had a chance to even get their first shots? Part of that is self-interest, because the sooner we can get the world vaccinated, the fewer variants that are going to be created and the less infection we're going to have. So it's in everyone's interest to make sure that vaccines accessible throughout the world. We'll continue to collect data, and one of the biggies, which we don't really have yet, but which people are sort of furiously working on, is how can we do a simple blood test to measure what we call neutralizing antibody levels. And those neutralizing antibodies are the antibodies that really fight infection or prevent infection. There's other kinds of antibodies that we can measure, even with existing tests. We can measure antibody to see if you had a previous infection, and we also can measure different antibodies to see if that person has responded to the vaccine in a general way. But neither of those tests are measuring neutralizing antibodies, which is really what we need to know. For most other disease states that we have vaccines for, like measles, mumps, rubella, everyone has had to provide evidence of immunity to a school along the way, showing that you got the shot and that the antibodies that are measured still give you immunity. So we have ways to measure that for other vaccines that we give, but it's really going to be important to have that for COVID, because if we can measure neutralizing antibodies, we'll really be able to maybe establish a cutoff of where you need to be that will both help us study the idea of booster shots and also identify people who might need a booster versus others who don't. But folks are working pretty hard on trying to develop a test for that would be easy to use and widespread. To kind of sum this up, the overall vaccine effectiveness is over 90%, even when we're talking about Delta. When Delta went from May or early this year from 2% of the strains that we were seeing to over 80%, and even 90% effective when a lot of restrictions have been kind of eased and there's probably less mask wearing. The rates did increase in both the vaccinated and the unvaccinated, but with much lower relative rates in the vaccinated. And although vaccine effectiveness declined, it's still quite high. It went from around 92% to 80%. The big question is, why did vaccine effectiveness decline? Is it that our immunity is wearing off, particularly for people who got the shots very, very early in the year? Is it just solely because we know that the Delta variant is much more transmissible? Or is it less masking and other what we call non-pharmaceutical interventions like social distancing and so forth? Or is it just a combination of those three? Probably is a combination. Identifying if it's waning immunity is an important question. This is kind of a confusing slide, but it's data from Israel where they have a much smaller population and started vaccinating very early and got very, very good coverage of the population being vaccinated. So it's a good population to study what's going on. And if you look from dark to lighter bars, those are the groups of folks and when they were vaccinated. And then the height of the bar is the rates of infections per 1,000 people. And you can see that in all age groups, the earlier you were vaccinated, when the bars are white, it was just limited to only high-risk folks. But if you look in the 60 plus, for instance, the earlier you were vaccinated in January, the higher the case rates. And so they're extrapolating from that people may be having some degree of waning immunity. So to sum up, for 1 million people over 60 with no booster, there was a greater than 10-fold reduction of severe illness and about an 11-fold reduction in infections. Overall, very good. And this is just kind of a graphic illustration of what happens when you have a really transmissible variant. Even if it's not necessarily a worse variant, it's just something about it that makes it much more transmissible. If you can see, looking back to May, this B117 is the so-called alpha variant, which originated in the United Kingdom, and that kind of came in that second wave. Most of our infections were that variant. The P1 was one from Brazil, was a small number, and then kind of a scattering of Delta here back in May. But as time went on and the year went on, look how Delta just crowded everything else out. So we're not really seeing anything but Delta right now. And it's pretty amazing how over that time period, in part because a lot of this is in the unvaccinated. And so really in the unvaccinated group, it's a little bit like we all were back in the beginning of the pandemic in 2020. What makes a new infection spread, and that is that no one has natural immunity when it first comes. There is some natural immunity in the unvaccinated because obviously some of the folks that aren't vaccinated have had previous infection, but we don't think the immunity is as good as a vaccination. So that just shows how dramatically Delta kind of took over. Briefly talking about some of the things that went into or is going into deciding whether or not to give boosters, but did go into the recommendation to decide boosters to the immunocompromised. And what they looked at was overall meeting to just look at when and how boosters should be distributed. They decided that at the moment, at August 12th, other than immunocompromised individuals, no fully vaccinated individuals need an additional dose. It was authorized for both Pfizer and Moderna, but they did not have enough data currently to make any recommendation about folks who've gotten the Johnson & Johnson vaccine. And they're continuing to look at that. Who they consider immunocompromised, who really should be getting that third shot, is any active or, in other words, current or recent treatment for a solid tumor, meaning cancer or hematologic malignancy like leukemia. If you're a solid organ or stem cell transplant recipient on immunosuppressive drugs, if you have one of the inherited severe primary immunodeficiency diseases, they included advanced or untreated HIV infection. There's adequate data in folks with HIV who were on medication with good T cells that they mount a great immune response and they don't necessarily need either a third shot. Certainly not the same way as transplant patients. But for people with lower T cells, even on treatment, or untreated patients, it would be important to vaccinate. And then some other categories of people on medications like steroids, certain drugs that are often used for different kinds of arthritis and other stuff, and then chronic renal disease potentially. So the people where there's clear-cut data are the transplant patients, as I mentioned. There's a gray zone for some other areas, but it's definitely something that people should speak with their doctor about. And again, this is why it'd be important to develop a test to really be able to measure that neutralizing antibody. Right now, they're recommending an additional dose. If you were a transplant patient and you just finished your 2-dose series a month ago, they're recommending you go ahead and get a third dose, potentially even right away. They're recommending that you try to get the same vaccine that you got at first. However, it would be acceptable to switch it up. And if you got a series of Pfizer, you could do Moderna and vice versa. You should wait at least 28 days after you finished your first series. For boosters, what they can accomplish is really with any vaccine, if you give a third shot or a booster shot, you're really going to get a very quick spike up in these neutralizing antibodies to the spike protein because your body remembers and can produce them very, very quickly. You'll get higher levels of vaccine effectiveness, which potentially could work better and increase the vaccine effectiveness for something like Delta or other variants that may come. We'll have fewer infections and therefore less potential for transmission. Fewer episodes of long COVID, some of the symptoms of fatigue or decreased concentration, shortness of breath that can persist for a long time after an infection. It looks to be much, much less common, 50% or more or less common to have longer term side effects if you got COVID, even when you're vaccinated. Another reason to get vaccinated. Even if you get infected, you're less likely to get long COVID. The risk of hospitalization from breakthrough probably would be reduced. Not by a huge amount because it's already reduced by a huge amount. Your chance of hospitalization is much, much lower, even just with one series of vaccine. We're not going to be able to reduce it that much lower, but we might be able to get a small effect. And the safety data suggests a similar response for second dose. The Moderna booster would probably be a half dose of what was given originally. So potentially fewer side effects than the initial vaccine dose. What are some of the concerns about doing boosters? It's the original vaccine against the original virus, so it's not Delta specific, although we know that it does protect against Delta quite well. We're using up that global supply of vaccine when we already know that most of the world population is still unvaccinated. Giving that booster shot to people that are already vaccinated, as I mentioned, is going to have kind of a limited impact on reducing the worst outcomes. Okay, what we're really trying to prevent, which is hospitalizations and deaths. Again, not because it doesn't work, but because we've already reduced it very, very much with the original vaccine. So on the margin, it's not going to be a huge effect. We should not make it a substitute for the primary goal, which is to get as many people as possible vaccinated with the first series. We don't really know, even now, how long the vaccine series or even a booster might work, and whether we need them every 6 months or every year, maybe only every 2 to 3 years. It's unclear. And then this question I kind of touched on, which we'll have more data on soon, is maybe doing the original 2 shots 2 to 3 months or 8 to 12 weeks apart instead of 3 to 4 might actually work better than having them closer together and give longer immunity. We don't really know. There's going to be some recommendations made. Currently in New York City, if you believe that you qualify for a booster dose, as far as I know, you can go to a pharmacy and just sign and say that you qualify based on these criteria, and you can get one. It's not really necessary yet, as far as we know, for most folks.
Are people with asthma and COPD recommended to get the booster shot now?
If you are someone who has COPD and asthma and either are on a daily basis on steroids like prednisone, or you require frequent doses of prednisone, prednisone falls in that category of kind of immune suppressive drug. It is used sometimes for asthma exacerbations and sometimes in chronic management of COPD. So if you're in that situation where you're on prednisone a lot, that might be a logical reason to go ahead and get a booster shot. We have a little better idea now for what helps and doesn't help in terms of treating COVID, both for the population that's not in the hospital and for the folks that are in the hospital. For people who are sick in the hospital, typically we'll get steroids, typically we'll get something called tocilizumab, which can decrease inflammation, and make it remdesivir. So those are the sort of 3 biggies. For people who test positive and are at high risk, that's the perfect person to get monoclonal antibodies. And there's places all over the city now where folks can get those. It does require an IV and an infusion, although in a pinch you can give it as a shot, but it has to be 4 shots, each arm and each leg divided up because it's a big amount of material. So typically we give it an IV. Getting those monoclonal antibodies decreases the hospitalization risk by 75-80%. You can't really get the vaccine for 3 months after you've got monoclonal antibodies, because those monoclonal antibodies are going to kind of work against making your own antibodies. Even if you're vaccinated and you are at high risk of progressing, it would be a reasonable thing to do. Delta is the overwhelming, what we're seeing now. MU, which is prevalent in Colombia and Ecuador. There have been some cases reported in the United States. It's currently, one of the talks we talked about, variants versus variants of interest versus variants of concern. It's a variant of interest, so not to the level of a variant of concern. It, like a lot of other variants that we've seen, may respond a little less well to the monoclonal antibodies, which they sort of do in a test tube and see how well they respond. So that kind of puts it on the radar to look at, but we don't know for sure yet whether it's something that we really need to be worried about.
You mentioned prednisone. Somebody who is on hormone therapy, like testosterone, which is technically steroidal, would that be something that would necessitate them needing a booster shot?
No, it really shouldn't. It doesn't have the same sort of immune compromise effect that something like prednisone does. So it shouldn't really have too much of an impact.
Okay.
But we got to keep getting that information out so people understand it and know it.
We're really over a year now from the start of the trials for the vaccines, and the safety profile kind of looks better and better the more people we vaccinate.